I can start. All right, sweet. I may make a start on the reproductive system. So in terms of the slides, I did go through your learning objectives, especially for the anatomy lab book. So I did put everything that you need to know on there. But I don't really have time to go through all of that in detail. So I'll just be going through the most examinable things. So I might make a start. Anatomy, all right. So in terms of the hip bone and just the pelvic girdle in general, I think all you really need to know is that it's made up of the hip bone and made up of the sacrum, and it is quite stable. In fact, the most stable joint in your body. The sacroiliac and the pubic symphysis help contribute to this. It's not really like the shoulder or the pectoral girdle because that needs to be more mobile. In terms of pelvic shapes, it's important to get your head around the fact that women actually have a much broader, wider hip, and that's for childbirth. It can actually get bigger during pregnancy because hormones allow the ligaments to relax, and that lets it become bigger. And males, of course, are narrow, they're more triangular. But women can actually have any of these 4 types, and that can present with problems. In terms of ligaments, these two, the sacrospinous, sacrotuberous, basically the 2 that you need to know. Our name is pretty self-explanatory, ischial tuberosity, sacrum, ischial spine, sacrum. But the most important thing about them is that they separate this area into the greater and lesser sciatic foramen. Really important in terms of knowing what sort of structures are transmitted. So this doesn't really show in this picture, but the piriformis, you guys should know the piriformis is this muscle that goes through here, and it separates this greater sciatic foramen into a suprapiriform and an infrapiriform foramen. And the infrapiriform is where all the important stuff goes through, like the pudendal nerve and the sciatic nerve, the biggest nerve that we have, which has all the innervation for the hip extensors and plantar flexors, which we'll go into later. But obturator foramen is quite easy to remember because it's just obturator artery, nerve, and vein. So, yeah. So if we go back to, it's really important to get your head around the orientation of the pelvis, because if you look from the front of a person, what you actually see isn't technically their pelvis, it's their abdomen, because the pelvic inlet is tilted forward at about 50 degrees. So all of this area here is actually abdomen, and that has all your abdominal viscera. And then you get to this, which is the pelvic inlet, which is from the sacral prom to the pubic symphysis. And if you go back here, you can see that there's this bony ridge called the linea terminalis, and that actually is probably the best marker you have of the pelvic inlet. And then that's the pelvis. And then underneath the pelvic outlet, that's when you have the perineum, which we'll go into later. A good way to remember this is that the aces and the pubic symphysis should be in the same vertical plane. That's how it should be oriented. So you know that in the pelvic cavity, you have parts of your gastrointestinal system, the end parts, and you also have your urogenital system. In terms of the borders of the pelvic cavity, it is important to remember that the side is made by the obturator internus muscles. And then underneath that, attached to that is the pelvic floor or pelvic diaphragm, another set of muscles, which we will go into. Remember I said that it's important to know the width and dimensions of the pelvic inlet for birth? Well, you can actually measure that to see how difficult the birth is going to be. So the one that you would want to get ideally would be the obstetric conjugate, because that's the distance that does not change, and it's the narrowest distance. It's from the pubic symphysis right in the middle to the sacral promontory. But it's quite hard to get just to feel, to palpate. So instead what they usually do is go for the diagonal conjugate, which is from the bottom of the pubic symphysis to the back of the sacral prom. And ideally that should be around 11 centimeters or bigger. Muscles, remember I said the pelvic diaphragm was really important, especially important for continence. So you've got your levator ani, which is these 3, and then you've got your coccygeus. The levator ani in particular is very important to remember the puborectalis. So this. And then you can see it has prerectal fibers. So most of the puborectalis actually slings around the rectum, and sort of holds it at a 90-degree angle, and that helps maintain continence. And then you've got these fibers that go around the urethra, and that helps maintain urinary continence. So obviously, when you've got some kind of damage to these muscles, you're going to become incontinent, such as in childbirth. And a good way to prevent that is to do an episiotomy, where you make an incision, actually through levator ani, but so that it's controlled tearing when you actually deliver the child. So it's a bit controversial, but they still do it. All of this is also innervated by the pudendal nerve. It's all somatic muscle. It's all voluntary and pudendal nerve, a somatic nerve. So that's a good way to remember it. S2, 3, 4 keeps the shit off the floor because it's from S2 to S4. Yeah. Cool. Vascular supply. So, I mean, it's kind of, I'm not going to list through all the arteries. The anterior division of the internal iliac is more important. Pretty much if you just remember that the internal iliac is what does everything here, everything in the pelvis, except for the gonads. Now, the gonads sort of operate differently to the rest of everything else in the pelvis, as the same with the blood supply. So think of the gonadal artery. It can be the ovarian artery, or it can be the testicular artery. Actually doesn't listen to any of this. It goes straight up to the aorta, and that's important to know. The venous drainage actually does the same thing. So the gonads go straight up, everything else goes to internal iliac vein. It's important to know that for the gonadal veins, the left gonadal vein actually goes straight into the left renal vein instead of into the IVC. And that means that it can get compressed there, and so you get backup of fluid, but it only goes to the left testicle. And then you can get, that backup can look like a bag of worms. It can give a bag of worms-like appearance, and that's called a varicocele, and that has a lot of clinical implications, but it's really all you need to know. Okay, nerve supply. So autonomic nerve supply is quite complicated. I wouldn't overcomplicate it too much. Just remember the basics of the parasympathetic and sympathetic system. So parasympathetic efferent is the pelvic splanchnic nerves, P for parasympathetic, and that's S2 to S4, so the most pelvic region, really. And then you've got sympathetic, and that goes from way higher up, and that's the lumbar splanchnic nerves. You don't need to worry too much about the hypogastric plexi. Just know that really technically it originates from the lumbar splanchnic nerves. So sympathetic is higher up, and parasympathetic is lower. It's sacral. And this is important because your sensory system of your viscera actually follows and travels with these efferent fibers back. As these ones come out, they travel back with them to the same nerve roots. So if you've got things that are intraperitoneal, they're going to go upwards with the sympathetic fibers. And then anything below that is below the pelvic pain line, and that's subperitoneal, and that goes with the spinal, with S2 to S4, with the parasympathetic fibers. Does that sort of make sense? I'll show you a picture. So that's the pelvic pain line, all right? That's the uterus. It's obviously not meant to be that big, but they're probably pregnant. And that's the cervix of the uterus. So you can see the cervix is below the pelvic pain line, but everything else is above. And so everything up here is going to travel with the sympathetics back to the lumbar system, and then everything below is going to go to the sacral system. So if you want to anesthetize in childbirth, obviously if you go from up here, you're going to get everything. You're going to get all of that because you're doing symp and parasymp. But if you go from more below, like just a caudal epidural, you're only going to get below the pelvic pain line. So you're still going to get some pain sensation from deeper inside the uterus. Okay. Have you guys had the lecture with this guy who showed you this picture? No? Well, this is a really interesting orientation of innervation in the pelvis. I would suggest sort of getting to know it. Could be very useful, especially since this is how you see it in surgery in real life from this angle. But yeah. Injuries in pelvic surgery. So, you know that sciatic nerve is going to be this really huge nerve. That's very important. And when you damage it, such as if you've got a prolonged lithotomy position or being in the birthing position for too long, it can sort of kink it. That can cause foot drop because your plantar flexors aren't working anymore. And then obturator does your adductor muscles. So Things like if you damage the obturator nerve, sort of if you're operating in the inguinal area, near the ovaries, you can have difficulty using your adduction. So things like getting into and outside of a car are actually use those muscles a lot. So that can be one of the most prominent signs. But yeah, this was in your learning objectives. I think, well, it was in mine, and it's quite important concept. So the pectinate line is what divides the ectoderm from the endoderm, all right? And it's 2/3 of the way down the anal canal. So everything above it is going to have visceral motor supply, and everything below is going to have somatic. Make sense? Another thing that's also important to know is everything above is actually portal circulation, and portal means it goes to and back from the liver, sort of almost in a closed loop. So the IMA is part of the portal circulation, and so is the SMA, and then portal venous drainage. So if you get a cancer there, it's actually going to drain to your liver. Whereas if you get an anal cancer that's sort of underneath the pectinate line, it's going to go straight to your IVC. So it's going to go in other places in the body first. And on to female reproductive anatomy. So I'm going to be talking a bit about the broad ligament because that was something that really took me a while to understand. It's really important because basically all of the other ligaments are inside the broad ligament. Pretty much the whole female repro system is inside. So we're going to start with the pouches. So if you imagine that this is your uterus, right? This is your bladder, so it's at the front. And then this is your rectum. The peritoneum sort of folds behind the bladder, up over the uterus, and then sort of comes back around, smacks on top of it, sticks it there, and then comes back and folds on top of the rectum. And that makes these two pouches, the rectouterine and the vesicouterine. And the vesico just means bladder, so that's between the bladder and the uterus. In men, they don't have this uterus, so they're only going to have one pouch, the rectovesical pouch. Whenever you have any sort of fluid, such as blood or pus that shouldn't be there, that's going to accumulate in this pouch, the rectouterine pouch in women. And clearly, because men only have one, it's going to accumulate in the rectovesical. But that's important to know. Moving on to the other ligaments. So you've got, these two are quite confusing, but you've got a suspensory ligament of the ovary and you've got an ovarian ligament. They're not the same thing. So the suspensory ligament of the ovary takes one side of the ovary and attaches it to the lateral wall, whereas the ligament of the ovary takes the other side and attaches it to the uterus. And that has like all the important vessels in it. And the round ligament doesn't touch the ovaries. It just goes straight from the uterus through the inguinal canal out to the outside of the perineum, or in women, the labia majora. So that helps prevent uterine prolapse. And then you've got these other ligaments, like they're not important, but they can just be confusing. So I'll just explain. The uterosacral just goes from uterus to sacrum, and then the cardinal just goes from almost the same distance. It just goes to the side of the pelvic brim. Yeah. And you've got these different parts that cover the different parts of the system. So the part that covers the ovary is going to be called the mesovarium. Salpin has to do with fallopian tubes, so that's going to be the mesosalpinx. And metrium, like endometrium, is going to be the mesometrium over the uterus. Yeah. And in most people, this is how it should be. The uterus should be bent forward twice. So it should be anteverted and anteflexed over the bladder. In a hysterectomy or a removal of the uterus, you do need to cut the uterine artery that's supplying the uterus. And this can be dangerous because the ureter runs right underneath, just like the phrase, water under the bridge. So something that they'll do in surgery is they may press against the ureter if they suspect that that's it. It can actually be really hard to see. But if it starts to wriggle, that's only ureters do that. Literally nothing else does that. So that's definitely the ureter. It's called vermiculation. Cool. Male reproductive anatomy. So in terms of these structures, I'm really going to be going through them in terms of what's most clinically relevant, like the pathology. So starting with the differences between the male and the female urethra. So clearly the men's urethra is longer because it has to travel a longer distance. This means that bacteria can actually get in easier to the female bladder because it doesn't have to go as far. So they're more prone to urinary tract infections. If you go through the sphincters, both men and women, they have an internal urethral sphincter and an external. The internal is always going to be innervated by the autonomic nervous system. So it's involuntary, whereas the external is somatic, it's voluntary. So that's going to be pudendal nerve because that's a somatic nerve. So you can control that, whereas you can't control that. And it's also important to know the parts of the urethra. So there's the pre-prostatic, there's the prostatic, and then there's the membranous or intermediate. We'll go into pouches later, but this is quite important because this part isn't protected by anything, so it's the most likely to be injured. And then this part's just the part that goes through the corpora spongiosum of the penis. So moving on. Okay, to understand what goes on in erectile dysfunction, you sort of have to understand the physiology of erection. So what happens is you get blood supply to the penis through the deep artery, and it fills up all of these little holes called lacunae. And what that happens, what that does is it actually swells up, and because this fibrous fascious sheath is quite tight, this, as it swells up, compresses this deep dorsal vein. And that means that blood comes in, swells it up, but it can't actually get out. And that's what maintains the erection. So what happens in ED, most commonly, the biggest cause is that blood can't actually get through the artery because of atherosclerosis. So in fact, if you've got systemic atherosclerotic disease, erectile dysfunction may be the first symptom. It's often the first symptom that the person gets. So yeah. Okay. Prostate pathology. So there's two main conditions you need to know. One's benign, and it happens in pretty much every male who's over 50. Very, very common. And it's called benign prostatic hypertrophy. This happens in a transitional zone. So that, in my idea, it should be called the central zone, but it's called a transitional zone. And it's where the urethra, the prostatic part of the urethra, comes through. So this is way, way more likely to cause difficulty urinating. All right? Whereas with prostate cancer, it most often happens in the peripheral zone. It's more palpable in a rectal exam because it's closer to the rectum. But the thing is with either of these is that when you're operating on them, you're pretty much operating in the same area. And that area is close to the periprostatic nerve plexus, which comes from the pelvic splanchnic nerves. So you're basically messing around the area where the autonomic nervous system is. So you can damage those nerves, and that can cause loss of parasympathetic supply and actually impotence. So that's important to be wary about. Now, for prostate cancer, you can spread a million different ways, but the one thing that's unique to prostate cancer is it actually shares its prostatic venous plexus. It drains back into the Batson venous plexus of the vertebra. So you can get metastasis first straight to the spine. In fact, that might be one of the first signs of prostate cancer. It's quite unique to it. Okay, the perineum. So this is everything below the pelvic outlet and below the levator ani, just before the skin. Do sort of know these triangles. Anal triangle is pretty self-explanatory, but the urogenital triangle is what's really complicated. I don't know how much you guys have had to do about this, but it was quite important for us. It is a very difficult concept, but you can learn it. I'll start from the most superficial layer of the fascia, of the fascial layer. So you've got the skin, right? And then you've got the superficial, or the perineal fascia. That's not the same as the perineal membrane. It's the perineal fascia, and it's continuous with the fascia of the abdomen. Now, I've written that there. Just ignore that. Pretty much think of the perineal fascia as a deep and superficial layer. Now, the superficial layer is called the colles, and it's continuous with the campus and the scarpas of the abdomen. Now, the deep fascia, forget about bucks, that just goes around the penis and it's very impenetrable. Whereas the deep fascia of the perineal fascia is, if you have to forget one thing, just forget it, because it's more important in terms of sort of an intermediate barrier to extravasation. Like it might be a bit there, might be a bit there, but it's not the most important thing. Then you've got your perineal membrane. All right, it's tough and it's right above the deep transverse perineal muscles. It's right below it, sorry. And only the urethra gets through, really, in the vagina and woman. And then everything above that is the deep perineal pouch, as you can see. And everything below is the superficial. So the deep perineal pouch is all of this like little space, this white space here between the bladder and that line and around. And that's a potential space. Usually there's nothing there, but that can fill up with fluid, and that can make that a real space. So if you look at rupture of the urethra, there's two main places it can happen. Really, only men are going to present like this, but you can have a straddle injury, or when you're inserting a catheter, it can damage part of the urethra. That's a spongy urethra inside the penis, and that is the most common site. And where that's going to extravasate is, remember that the perineal membrane separates superficial and deep. So that's going to go below the perineal membrane. So that's going to go into the superficial pouch, and it can sort of get through all of these intermediate or galordates fascia into different sections. So like it can go into the testes, it can go around the penis, it can go up into the abdomen, because remember that blue line is the abdominal fascia. So the superficial pouch is below that. So that's the presentation that you can get. You can get swelling everywhere, all the way up the abdomen. Whereas with the intermediate urethra, it's actually right where the perineal membrane is. So really what happens is it goes upwards and it makes fluid build up around here. That's the difference between them. Okay, does that sort of make sense? Sweet. Embryology, just remember that, the analogs between these structures. So remember that, for example, the genital tubercle is going to be the glans penis in a male, and it's going to be the clitoris in a female. And you also get a urogenital sinus. So in men, what happens is that that whole process just stretches out and that closes. In fact, if it doesn't close, it's pathology. It's called a spady, and it causes bunches of problems. Whereas in women, it stays put and that becomes the vestibule. Sensory supply of the perineum. Most of it is going to be through the sacral nerves, because most of that is through the pudendal nerve. And the pudendal nerve is, remember, S2, 3, 4, keeps the shit off the floor. That's the pudendal nerve. So in terms of the travel of the pudendal nerve, remember I said that it was important to know these foramen. So you've got your piriformis there, haven't shown it, and you've got an intrapiriform foramen. And your pudendal nerve goes into the intrapiriform foramen. It hooks around the ischial spine, comes out into the lesser sciatic foramen, and then it goes through this sheath. The sheath is between, so you've got your obturator internus muscle, and then you've got the fascia of the obturator internus muscle. There's a separation between them, and that's the pudendal canal. And that's where it goes through underneath the pelvic diaphragm and into the perineum, where it does all of its stuff. So lymphatic drainage. Honestly, don't bother too much with learning the complexities of it. Just know that the gonads, or the ovaries, or the testes are going to go straight up, just like their blood supply, straight up to the para-aortic nodes or lumbar nodes, whereas everything else sort of behaves more reasonably and it goes towards the inguinal nodes in various orders. You don't need to know them, but yeah. Cool. Histology. You guys done much histology? Yeah, sweet. Okay, so the uterus endometrium is just one of the layers. There's a myo, which is all muscle. There's a peri. Just know that the endometrium should have a functionalis, or functional layer, and that's the part that sheds, and then a basalis, which is the part at the bottom, made up of all the basal cells that sort of regenerate that. Now, the difference between proliferative and secretory. Proliferative is it's proliferating. The glandular cells are dividing, but they're not secreting just yet. So you have lots of mitosis, but you don't have secretions. Whereas in the secretory phase, they're not dividing anymore, but they're secreting. So you're going to have no mitoses, but a lot of fluid. That's the difference between them. Ovaries is also simple. This time it's simple squamous or cuboidal, outer epithelium, not really that important. It does have the cortex and a medulla. Medulla is just supportive. Cortex is where all the follicular genesis happens. We'll go into that more later. Testes, this is the seminiferous tubule, and this is where all the spermatogenesis happens. So all of those little white circles, they're all sperm, right? And all of that in the middle, that's all the tails of the sperm. And they're all in the lumen of the tubule, and they all sort of swish together, and a sperm sort of makes its way out from the outside to the inside and then into the whole drainage system. There's two cells you need to know, the Leydig and the Sertoli. Now, the Leydig are not actually inside the tubules, they're outside in the interstitial space, and they produce testosterone. Testosterone is what drives the whole spermatogenesis process. Now, the testosterone produced here needs to get inside the tubule to act. So it diffuses through because it's a steroid, and steroids can go through anything that they want, but it could diffuse out if it didn't stick to something. So that's what the Sertoli cells do. They secrete ABP, and that binds to testosterone so it can stay there and keep doing its stuff. In fact, the Sertoli cells are quite hard to spot because there's only a few of them, and they sit like in between all of these sperm. And there's one there. It's sort of like a tree branch. It goes straight from the outside, the inside. They help make the barrier that protects the sperm from the immune cells of the blood. Also secrete inhibin, which actually, interestingly enough, has the opposite effect. It stops sperm production. It's a self-regulating cycle. It also has all these other functions, which are important to know. But yeah, spermatogenesis. So remember, you need testosterone. You also need FSH, which spikes in puberty. That's why you get spermatogenesis again. But basically, you start off with spermatogonium, and then they keep dividing, and then eventually decide to start getting real and becoming a spermatocyte. It's going to start the process. So it has the normal number of, it has twice the amount of DNA to start with, and it splits to become a secondary spermatocyte. This is the same as your normal cells. One set of DNA, two sets of chromosomes. And then they split again through meiosis 2, and that becomes only one set of chromosomes. And then they sort of mature a little bit, get a tail, and they're called spermatozoa. Important to know is there's this thing that's not in the picture, but I tried to draw it. It's like a syncytium. It's a shared membrane between the four because only some sperm have X chromosomes, but every sperm needs the things that are made by the X chromosomes, like nutrients, and enzymes. So if one sperm has the X chromosome, it can make these and share them across. So that's what the syncytium does. I'm not going to go through this too much because I don't think it's that important. Just you know that there's interphase, prophase, anaphase, and then telophase. Prophase is where they sort of start to line up and separate. Metaphase, they do line up. Anaphase, they start to separate. Telophase, they're done separating. And it does it again, but separating the individual chromosomes. And just know that there's a lot of variation because some genes like to jump across in prophase, and that's called crossing over. And also the chromosomes can line up with whatever they want. So that's independent assortment. So once the sperm's matured, so it has to become a spermatozoa. So it has to get rid of all of its cytoplasm, and that's called nuclear compaction and cytoplasm discardation. And then sort of make this tail. The Golgi complex is enzymes. Remember that. So it becomes the acrosome because you need the acrosome. You need all those enzymes later on. The middle piece is what has all the mitochondria that burn and make the energy that sort of helps the sperm to move. And I mean, it's pretty self-explanatory, the journey that it takes. Just know that most of semen is actually from the seminal vesicles. Only a small percentage of semen is the actual sperm from the testes itself. Most of the semen itself is supporting fluid, like fructose for the mitochondria, and that comes from mostly the seminal vesicles and also from the prostate. Okay, so two things you do need to know are cryptorchidism, or undescended testes, and testicular cancer. So you probably might have learned in GIT that the testes start in the abdomen and then they go through the inguinal canal and they go outside the body because they need to be kept cool. Otherwise, they'll die off. So the body's too warm for them. They need to hang outside. So if this doesn't happen, they die off and you don't see any sperm in the actual tubules. And you're more inclined to get cancer, which can, because testes descending should be done by 9 months old. So you're more likely to be young when you actually get cancer. Now, the thing about all the accessory glands, like the epididymis, vas deferens, seminal vesicles, is they're all contractile because they all help in ejaculation. So they all have smooth muscle in their walls. That's the more important thing you need to know, as well as the fact that sperm maturation is really an ongoing process, stepwise process, and it doesn't finish with sperm maturation. All the way until like they enter the vaginal tract, it's still going on, and part of this process is done here. Okay, question time. I think I'm just going to start from that end, and you can just give it a go. And if you don't know, you can pass. But like, yeah, they are kind of hard questions. So, key thing here is it's her cervix that's been stimulated. So where does cervix pain refer to? A? Perfect. Yep, because it's cervix is subperitoneal. Remember the pelvic pain line? Everything, the cervix and everything below is subperitoneal. So it's going to go with the parasympathetic nerves, which go to S2 to S4 roots. Remember, the perineum is mostly supplied by S2 to S4 roots. So, of course, forget about the lateral portion of the thigh. That's confusing. Just remember it's the perineum that you feel the pain. Okay, your turn.
I have no idea. Is it D?
Not quite.
Oh, wait.
So which one is it, A or C? It's going to be kind of mean.
I'm just going to go with C.
Yeah, woohoo, you're right. Because it's almost like a memorization thing, really. But yeah, they originate from the genital tubercle. So yeah, just look at that picture again. It'll be good. So you've got a male. He's had rupture of the urethra, and it's gone to his abdominal wall beneath the fascia. Where do you think the initial extravasation should be located? So where did the blood come from? Where is the blood, really? Yes, correct. So what are the borders of the superficial pouch? Now, the fascia of Gaulodet is the deep fascia of the perennial fascia. So it's like the deep layer of the perennial fascia. It's technically really just another part of the perennial fascia. Correct, because the perennial membrane separates the deep and the superficial fascia. Oh, whoops. Yeah, what part of the urethra is most likely injured? Yes, correct. But yeah, so this is the picture I'm talking about here. So you've got your perennial membrane there, and then you've got deep perennial pouch above and superficial below, and then the Gaulodet fascia is really just like these intermediate layers. But really, what's important is that it's underneath the perennial membrane. So you're correct. Yeah. Gaulodet is like so you've got your superficial fascia, that's the Colles fascia, and then still in the superficial pouch, you've sort of got these intermediate layers of fascia that are called like the deep layer of the perennial fascia or the Gaulodet's fascia. I wouldn't worry too much about it. In fact, that was probably a really badly worded question. Just know that it's below the perennial membrane, and that's the Colles fascia there. So it's really between the perennial membrane and the Colles fascia. So yeah. So it's the external urethral sphincter, what innervates that. Correct. Because it's a somatic muscle. The external sphincter is somatic innervation, and pudendal is a somatic nerve, so you can control it. Unlike this question. So he had a prostatectomy, and then he became impotent. What was most likely damaged? You can pause if you don't know. Yep, because P for parasympathetic. And yeah, a good way of remembering it is point and shoot. So P for parasympathetic, point. So it causes the erection to happen, and then shoot is ejaculation. So it's sympathetic. So to be able to have an erection, you need your parasympathetic system to be working properly. Yeah. So seminoma, testicular cancer. Just forget about the whole rest of the stem. Where does testes lymphatic drainage go to first? Correct. So remember that the testes and the ovaries are both the gonads, and they don't listen to wherever the rest of the pelvic organs like to go. Everything else in the pelvis sort of goes to inguinal or iliac. It doesn't matter which order, they all go around there, whereas the gonads themselves go straight up to the aorta, just like the blood supply in the venous drainage, because that's actually where they originated and they descended from there in embryology. So that sort of makes sense when you think of it that way. So pudendal nerve block, what's close to the pudendal nerve? You say E? I see. Close, not quite. A. Yeah, I know it makes like you're thinking what could be probably most palpable, but this is just like literally what the question's asking is what's the closest structure. And so you can see it hooks. Remember, it hooks underneath the ischial spine as it goes into the lesser sciatic foramen. So you know that that's definitely going to be the closest to your pudendal nerve. All those options could work, but this is the best option. Yeah. Yeah. Yeah, correct, because that produces most of the supporting fluid, and one of those things is the energy, the fructose. Correct. The bulbourethral glands are they don't really do much. They just sort of make like this pre-ejaculate fluid. You don't really need to know about it. Prostate gland is the next most important one, but not fructose. Okay, physiology. So starting from the egg, oogenesis. You get primordial germ cells, and they sort of go to the gonads when you're still a fetus and start to make oogonia. And then they start to undergo meiosis, just like the sperm do, but then they arrest before it even really starts in prophase 1. And you have a finite number of these. They drop off as you age. AMH is, I would know these numbers. AMH is something we don't really know how it works. It's not really the best marker of menopause, but we do know it has to do with the number of follicles that are being recruited at a certain time. So it can be an indication of how well your ovaries are making eggs. But moving on. So start with the ovarian cycle, where you get a follicle, it matures, and then it sort of pops off and goes to be implanted. The only difference between a primordial and primary is that the layer surrounding the oocyte is originally flat, and then it becomes cuboidal. So if you look here, okay, that's probably an early, like, secondary spermatocyte, but like, just pretend that that's a primary. See how these cells are like quite visible, whereas you can't really see, you just see sort of a surrounding layer. That's the difference between primordial and primary. And then secondary, these cells become multi-layered, and they're called a granulosa, and then you get this very obvious, that's why I thought this was a secondary, because you can see there's a zona pellucida. That's a glycoprotein layer, and it's important later on. So these granulosa cells, I'll show you, they're important because later when it becomes an antral follicle, you get these cells outside the granulosa called theca cells. So there's theca interna and externa. They're sort of spindle-shaped, and the interna is what makes androgens like testosterone. And then these sort of float into the granulosa, and then the granulosa turns them into estrogen, and that further drives follicular genesis and getting ready for a pregnancy. So that's what makes the estrogen. It's the follicle itself once it's become an antral follicle. And then remember, it gets this antral cavity of fluid, and one becomes dominant and bigger, and then it gets ovulated. And then the remainder, which is everything besides this oocyte and its corona radiata, that's what gets expelled. Everything else becomes the corpus luteum. You can see there's some pictures there. So in terms of what stimulates the cycle, FSH in puberty goes up, spikes up. I'll go into that later, but then that causes it to start happening. And then once you get these formation of these antral follicles, they take over because they start making estrogen, and that keeps going. And then you get this development. It's a variable length. change depends on different people, but then what happens is you get an LH surge. Now, everything else surges. Estrogen also surges. Usually it's inhibitory, but then it becomes positive feedback right around ovulation, but that's not as important as this. This is the thing that you want to remember, that LH is the main thing which triggers ovulation at the time of ovulation. It's a massive spike. That's what's most important. So I'll go into progesterone later, but just moving on to the menstrual cycle. So this is driven by the ovaries. So this ovarian cycle actually ends up influencing the menstrual cycle. And it's where the endometrium of the uterus changes. So let's start with the end of the cycle. Let's start with the late secretory phase. What happens is you don't get implantation, and so this thing doesn't get a signal that it needs to survive. And so it degenerates. And that signals prostaglandin release, and that signals vasoconstriction. So the arteries supplying the endometrium just constrict, don't let any more blood through, and it dies. And that's dead tissue that then gets shed. That's the stratum functionalis, and that gets shed in the menstrual phase. That's day 1 to 5. That's the start of your cycle. And then, of course, it needs to build up again. So it builds up again. That's proliferation, division of vessels. And then afterwards, this luteal phase, that's your secretory phase. That's where you get secretion of glycogen because it has nutrients as well as a million other things that help for implantation. That's a good summary of both of them together. Fertilization is really just knowing the steps that go on, starting with the sperm prepares, then it penetrates the zona pellucida, and then they fuse, and then the egg's activated and starts replicating itself. So starting with the sperm preparation, we don't know how it happens, but once the sperm enters the female tract, it matures further, and then it undergoes the acrosome reaction. So that's where this acrosome, upon binding to the zona pellucida, sort of like breaks down, and all those enzymes get released. And that's important because to penetrate the zona pellucida, first of all, it's really these two steps are sort of together, because what happens is it binds to ZP3, one of the glycoproteins in the zona pellucida, and that actually is what induces the acrosome reaction. And then what ZP3 does is it uncovers these ZP2 binding sites. So then that will only bind to the sperm that has lost its acrosome. And so this is this ongoing, like this sort of interworked process that allows the sperm to penetrate the zona pellucida and break through inside to where the egg is. And then after that happens, the oocyte and the sperm membranes, they fuse. And it's just important to know that the egg contributes CD9 and the sperm contributes izumo, which are both important for this process. They're really just like buzzwords, good to know. And then the egg gets activated. So what happens is the zona pellucida sort of changes because of these granules in the acrosome that are excreted, and it modifies the structure so that no more sperm can get through. And then it also, what happens is the cell cycle resumes. So it starts dividing. They join their DNA and it divides. All of this is triggered by intracellular calcium spikes. No one really knows what causes it, but there's a couple of theories. And the most accepted theory is the sperm factor model, where the sperm actually brings a little thing with it called phospholipase C zeta, and that, once it's inside the fused membranes, that's what triggers the intracellular calcium spikes. So you've got your egg, it's been fertilized, it's going to start dividing because it's been activated. Once it gets to, so that's a zygote at this stage. Once it gets to 16 cells, it's called a morula. And you can see as this is happening, it's traveling all the way along the fallopian tubes and into the uterus where it's going to be implanted. And then what happens is after it loses its zona pellucida, it sort of makes this cavity with an inner cell mass and an outside trophoblast. This inner cell mass is what's going to become everything that is the baby. And the trophoblast is supportive because it has this syncytiotrophoblast and a cytotrophoblast, and they're what help stick it to the inside of the uterus, and then they start making HCG, human chorionic gonadotropin, which tells the corpus luteum not to die, to keep doing its thing, because it has a baby, it has an embryo, and they're going to try and make a pregnancy. It's this is sort of clinically relevant because HCG is what you test for in a pregnancy test, but you can't test it immediately because implantation takes 6 or 7 days after the zygote actually matures. So that's probably about 2 weeks after actual ovulation. And yeah, so your corpus luteum makes the progesterone. Eventually, the placenta takes over. We'll go into that. 2 important things to know is placenta previa is when this implanted blastocyst sort of implants too close to the internal os of the uterus or the entry point, and that can cause a lot of problems like detachment. Ectopic pregnancy, this is important because this is what happens when the zygote actually doesn't go all the way down here. It might get stuck here, or it might actually float out into the perineum here and start implant somewhere else, start to grow, and then die and cause massive hemorrhage and death. It can cause death if it's not treated. And the most common site for it to implant is the oviduct, or this part of the fallopian tubes. That's the most important part. Extraembryonic membranes. So the most important one to know is the chorion, because that's the fetal component of the placenta. So your placenta is, it's a transition point between the baby and the fetus, and the mother. It's very important that it's supplied properly, that the blood supply is adequate, because if not, it can cause this syndrome of fluid retention, protein retention, hypertension that damages both the mother and the baby. But moving on to the actual blood supply itself. So there's a fetal component that's from the chorion, that's these chorionic villi. And then you've got a maternal component, and this is all the uterus, right? And then you can see there's this blood, this hemorrhage from the endometrium of the uterus, sort of pulls around these villi, and that's the maternal component. So it's a mutual thing. What it does is it transports things like nutrients and waste, makes a barrier so white cells can't attack the foreign genotype of the baby, and it also synthesizes and secretes hormones, which is important. I'll go into that later. But you do need to know what can get through and what can't, because this is the kind of thing that you would recommend to a pregnant mother, what she can have, what she can't have. Blood doesn't mix. Even though they're very close to each other, the blood does not mix. However, what does mix is alcohol, drugs, nicotine, and some pathogens, all the things you wouldn't want to cross into the baby and hurt the baby. So that can actually cause fetal alcohol syndrome if alcohol gets through. It can cause things like death, retardation, and then things like blood cells. Remember, blood doesn't mix. Hormones, immune cells, they just don't get through. Amniotic fluid does a lot of functions. So it makes space so that the lungs and the muscles can sort of grow, and it also forces the gut to swallow and to learn how to swallow, and in doing that, develop itself. Again, mechanisms of transport, it's sort of similar to this. Just know that water, gas, urea, free fatty acids, that's sources of nutrition, and drugs, they can all passively diffuse, so it's very easy for them to get through. Whereas everything else sort of follows what you would think for the rest of the body, like lipids need receptors to actually get through. So hormones, which, remember, the placenta secretes hormones. So hormones that it secretes, after the corpus luteum sort of reached a point, about 8 weeks after the implantation, the placenta takes over and it does all the same stuff it was doing. So it makes the progesterone. This is a bit confusing. I didn't mean that it causes abortion. What happens is that when you block progesterone, it causes abortion. And then the placenta also makes estrogen. All of these help prepare for pregnancy, prostaglandins, HCG, a few other things. And what progesterone actually does is it inhibits the muscle of the uterus from being excited too quickly and expelling the baby too quickly before it's ready. So what happens closer to pregnancy is that P4 sort of goes down, and then, there's less of it. Well, actually, no, that's not correct. P4, it's not that there's less of it, it's that it switches to a different type of progesterone, which just doesn't really have an effect. And you get more estrogen effect, and that causes more contractions. So you get these false Braxton Hicks contractions and eventually the real stuff. So P4, progesterone antagonizes estrogen, that helps this whole balance. And you can see that in terms of how it synthesizes hormones, it actually doesn't have the substrates necessary to do this. So they sort of come in from the mother and from the fetus, all the substrates necessary, and they diffuse into the placenta, and then the placenta turns these into progesterone and into estrogen. And things like DHEA and 16-hydroxy-DHEA, they're made specifically by the fetus. Yeah. Now, in pregnancy, most things really just go up. So your weight, okay, your blood supply, your blood volume, cardiac output, your breathing changes, it becomes deeper, and your hormones will go up, so does your glucose, and you retain more fluid. So everything goes up, and most of this is in adapting to the pregnancy, getting ready for it. Some things are a side effect of the increased progesterone, like vasodilation, which causes constipation, syncope, a few other things, but most of it's intentional. As the fetus matures, it's important to know that birth weight makes a huge difference as to the outcome of how well it does after it's born. So if it's too low, it can cause a lot of problems. If it's too high, it's usually due to maternal diabetes, and that can also cause problems. The main things that influence endocrine control, these three hormones, remember them: growth hormone, T4, thyroid hormone 4, and insulin. They have the biggest effect. And remember, the fetus has to mature its lungs, make energy, get all of its other organs ready. Important to know that actually surfactant, when you did the respiratory system, you've learned about surfactant, which keeps the alveoli patent. The production of surfactant actually only goes up right before term delivery. So if you get a preterm baby, they probably don't have enough surfactant, so they're more likely to have infant respiratory distress syndrome. And you can use lecithin. You can test for lecithin, which is an indicator of how much is produced. This doesn't really matter because we don't really know what effect it has. It's just something we know happens, the cortisol surge. So, okay, so parturition, birth. Again, we don't know what actually triggers birth, but we do know that the signal comes from within the uterus. Two important things you need to know: uterotrophic factors and uterotonic, and the difference between them. So uterotrophic has to do with growth, trophic, like preparation. So it prepares the uterus for contractions, whereas tonic changes the tone, it induces contractions. And both of these are inhibited by progesterone, which doesn't want the baby to be born too early. And then once the balance shifts and estrogen becomes dominant, that's when they're potentiated and it's time for the baby to be born. Prostaglandins also cause contractions, so very important. Oxytocin in itself is probably the closest thing that we know actually causes birth to happen. So we don't know what comes first, secretion or the baby moving further down the canal, but one further stimulates the other. So say the baby moves down the canal, that causes pressure receptors to excite the hypothalamus that says make more oxytocin, and the oxytocin causes contractions, which force the baby down further and causes the same pressure receptors to be stimulated. So that's the Ferguson reflex. And then in terms of the stages of birth, you initially get relaxation and dilatation, and then contractions, and then delivery. And then what happens afterwards is you need to get rid of the placenta. So that just sheds off because the body doesn't want that anymore. Lactation is really the same concept as the Ferguson reflex. You get mechanical stimulation, which causes oxytocin secretion, which further causes mechanical stimulation. And it's just a positive feedback cycle. In fact, the body doesn't really have many positive feedback cycles. This is one of the few ones that actually exist. Most of them are negative. And after you're actually born, you don't get any more progesterone and estrogen production, but they still sort of linger around and they inhibit prolactin. So you don't get proper breast milk secretion. You sort of just get this half and half colostrum. But that in itself is very functionally important because it has antibodies and it has lots of protein that the baby needs in the first couple of days. And then the rest of the remainder of the progesterone and the estrogen sort of just is gone, and your prolactin can take over and really cause breast milk production. Puberty. So the one thing that's important is that kisspeptin is what starts the whole process. Just remember that it's the top of the ladder, and then it affects the hypothalamus. and you start getting these GnRH pulsatile spikes. They start at night, and eventually they become just day long, and they make FSH and LH climb, and LH stimulates the Leydig cells to produce testosterone. That has all the effects of puberty. And then in terms of the important puberty details, really, the Tanner stages are there. I'm not sure how much, we didn't really need to know them that well, but they're good to know. Menarche, or the first period, usually happens around 12 and a half years old, but it changes across different populations. Coleman syndrome is a type of hypogonadotropic hypogonadism. So what that means is failure to go through puberty because your gonads aren't working. And what causes it is there's this mutation which stops these neurons that make GnRH or gonadotropes to migrate from the nose to the hypothalamus. And so the first sign you might actually get may be anosmia, which is difficulty, you can't actually smell. So that's an interesting thing to know. Testosterone, so there's actually 3 main types of pathways. One is direct, the other is dihydrotestosterone, and that's what does a lot of the secondary sex characteristics like muscle mass, libido, testes enlargement, all of that, and hair, that's all like DHT. And then some of it gets converted to estrogen, which is important both for men and women because that's important for brain and bone development. Infertility, okay. The biggest cause of infertility is we don't actually know what causes it, but we do know that a lot of infertile men do have androgen deficiency, like 1 in 7, and that contributes to the infertility. And so we can actually treat that. So that's important to know. It's one of the few things we can treat. And you can supplement it with clearly testosterone so that they don't get all these symptoms of having not enough testosterone. However, be careful when treating with testosterone because I'll go into it later, but testosterone in itself can cause infertility because it has a negative regulatory feedback mechanism on the hypothalamus. But yeah, and Klinefelter's is when you get an extra X chromosome, and that can also cause androgen deficiency. In terms of the sexual response, really the main things to know is that the first part in men, the erection and the plateau, that's all done by the parasympathetic system. And then the ejaculation is done by the sympathetic system, or the next 2 stages of the cycle. So point and shoot, remember. Another thing is that in women, during the plateau phase, the inner part of the vagina actually tense. So remember, you've got your uterus is antegrade and antiflexed. No, anteverted and antiflexed. So that becomes like vertical in the plateau phase, just because it's easier for the sperm to actually enter. Menopause. So that's when you're starting to lose all of your oocytes. They're all sort of dying off. Because remember, when a dominant follicle gets chosen, the rest sort of just undergo atresia. They die off. So this happens usually around 51 years old. Do understand these technical terms and the difference between them. Menopause is the final menstrual period in a woman who has not had a hysterectomy. And you can't really tell when menopause is happening until afterwards. So it's a retrospective diagnosis. So is really the rest of these, because this is perimenopause. It's the time from the onset of irregularity through until 12 months after the FMP. So it's like, again, a retrospective diagnosis. And then the menopause transition stops at the FMP. It goes from irregularity to the FMP, and it doesn't continue for 12 months after. Weight gain in menopause isn't actually due to menopause, but you do get changes in adiposity, which I'll talk about here. You get more fat distribution around your abdomen and around your viscera, and that's way more dangerous than just getting fat in general, because it can cause metabolic syndrome, it can increase your risk of cardiovascular disease. You get all these other disturbances like mucked up like cholesterol and LDLs and triglycerides. It's all around the place. And then you get insulin resistance, which is, metabolic syndrome. Part of that is diabetes, and part of that is insulin resistance. And then your vessels start to go haywire as well. You get endothelial dysfunction. So basically you get this myriad of cardiovascular risk factors and disease. And so before menopause, women's rates of cardiovascular disease are significantly lower than men's, but then after menopause, it evens out because of this, because estrogen is actually protective. Osteoporosis is your lack of estrogen causes osteoclasts to become more active and to start breaking up the bone again, and so that causes more fractures. In terms of your short-term systems, what causes hot flushes is normally your body has a thermoregulatory zone, which is the amount of temperature changes that it can handle without having any symptoms. And this becomes narrower in menopause. So that causes you to get more symptoms like hot flushes. And then you get weird, funny things like formication. You also get anxiety, a few other things. But these highlighted ones are the ones you really need to know because they're most clinically important. Okay, premature ovarian insufficiency. It's when you get menopause before you're 40 years old. You can have it as a cancer patient when you undergo radio or chemo that kills all of your eggs. So that can cause it. There can be many people, we don't know what causes it. In terms of what we do know causes it is a certain couple of syndromes. So there's Fragile X, where you get this weird CGG repeat. You can be a carrier of this syndrome where you don't have enough repeats to have a real clinical syndrome, but you can still become prematurely menopausal. So a lot of people who have menopause before they're 40 may carry this syndrome. Turner syndrome is more obvious. It's when you only have one X chromosome and you have a couple of characteristic things like short stature, a webbed neck. Yeah, okay, onto questions. We're close to being done, so we might start at you again. Yeah. Correct. They bind testosterone, but they don't produce it. That's the Leydig cells. Cool.
So 7 years old. What is it like? 45XO?
Yeah, correct, because they're missing an X chromosome, and I sort of told you just then, but yeah, webbing of the neck is something that happens in Turner syndrome, as well as being short. Sort of just buzzwordy things, but yeah. Cool. It's D. So I had to remember it myself there. But what happens is when you get the corpus luteum, it secretes estrogen and progesterone. And it actually, once you get implantation, the corpus luteum persists. It doesn't die. And when it persists, what it wants is for the body not to produce any more eggs. So the estrogen and progesterone that it keeps producing has this added function of going back to the hypothalamus and saying, no more LH, I don't want any more eggs being made. So that's what causes LH to go down, because you don't want any more follicular genesis while the fetus is maturing. Does that make sense? Yeah. Which of the following could inhibit the initiating of labor? It's kind of a hard question. You can just take a guess. Like, it doesn't really matter if you get it wrong. We're all learning. But yeah. Someone say C. Correct, because prostaglandins initiate labor. And so if you inhibit prostaglandins, you inhibit initiating labor. All right, this at the start is actually kind of confusing because remember, if you antagonize progesterone before it's time for the baby to be delivered, it'll cause premature delivery and that'll cause abortion. But this is when it's time for the baby to be delivered. So if you antagonize progesterone, really, like, you're not making any effect because it's already being antagonized right before the baby's born, because it needs to be for the baby to be born. LH, that works on the ovaries. It has nothing to do with labor. That D is probably going to cause labor to be initiated, as is oxytocin. Remember the Ferguson reflex, so it's C. Oh, sorry. Correct. Yeah, so I'll explain this because I feel bad. Yeah, so pretty much estrogen also switches to positive, remember that, but what I try to emphasize is if you get this kind of question, it's always going to be LH, because that's the main thing that we know is the most important thing causing ovulation. So nothing else really matters. It's just LH. LH. Searches. Yeah. Correct, because progesterone and estrogen are important for maturing the breast, like developing the ducts and the glands that it needs. However, it does suppress prolactin, and prolactin is what causes milk to be produced. So during pregnancy, you don't get milk production, but then after pregnancy, the progesterone and the estrogen, they fall, and that's when you start getting prolactin activity and you start getting lactation. None of the other answers are. Yeah, of course. Wait, hang on. Wait. Yeah. That's a silly answer. Correct. So remember how I said I'd talk about later the effects of testosterone and how it can cause infertility if you actually give someone testosterone? That's because even though testosterone stimulates the spermatogenesis, it regulates itself. So it also inhibits the hypothalamus from making the same hormones that actually stimulate spermatogenesis. So it does both. It causes it and it inhibits it. It's just can't decide. But yeah, that's what causes the fact that they're sterile. Cool. You say E? Not quite. Does do something. Correct. So the placenta does synthesize and secrete hormones. So it doesn't get the substrates. It doesn't have the substrates itself. They come in from the mother and they come in from the fetus. But then it does eventually turn these into progesterone and estrogen and then secrete them. So it does have that important function. In fact, it's the main thing that actually produces these in pregnancy, these very important hormones. Okay, I'm literally almost done. I'm just going to have a couple slides on microbiology. I know you only had one lecture on this, right? Do you have it today? Okay. It is still important to know like a few things, specific things. So I will go through it quickly. Basically, there's like 6 things that you need to know. HPV, HIV, yeah, they're all there. The main ones. HPV, know that you probably would know that it causes cervical cancer, right? That's why you get the immunization. Do know that it does cause other cancers as well. It causes anal, vulvar, penile, and oral cancer, as well as cervical cancer. So it can cause any of those. HIV, you guys probably know quite well, so I might just skip over that. Information is there. As I said, everything that's in the objectives is here, but just explain things. Genital herpes is herpes simplex virus, and there's a bunch of herpes viruses, but this one is what causes the genital herpes subtype. The difference between this in terms of symptoms and syphilis is both of them cause genital lesions, but in herpes, it's going to be painful, whereas syphilis, they're completely painless and they're called chancres. So in genital herpes, you do get quite a lot of pain. However, do remember that for most of these, a lot of people are actually asymptomatic. And that means they can still get things like the complications like infertility, pelvic inflammatory disease, but they just won't know about it because they're not getting any symptoms. For genital herpes, this is the only one that you'll learn that condoms don't actually prevent transmission. So you can't actually prevent transmission of this without completely abstaining. So that's the unique thing about genital herpes. And Remember I said the placenta can transmit pathogens. In fact, it's very easy for them to come through. This is one of them. This can cause death of the fetus. Chlamydia. Chlamydia trachomatis. A good way to test for it is to do an ELISA or a specific antibody test, unlike syphilis. But yeah, I think for chlamydia, that's really all you need to know. For gonorrhea, do remember that it's gram-negative diplococci, not gram-positive, gram-negative, because I forgot this and I hated myself. But it's gram-negative diplococci, and like it's very characteristic. Gram-negative is going to be purple. No, pink. Sorry, pink. It's going to be pink, not purple, because it doesn't take up the purple stain. A lot of people who have gonorrhea actually have chlamydia as well, and likewise. So it's important to test for both when you've got a diagnosis of one of them. And this, just like HIV, is a notifiable disease because you just need to let the government know because it's very infectious and it has a lot of, you need to test the carriers, you need to do a lot of investigations for it. Syphilis, our last thing for today. So treponema pallidum. There's 4 stages of infection, getting increasingly severe. So start with primary infection. That's where you get your painless genital lesions called chancres. And then secondary, you get infected again, but you get a rash, and it's much more of a syndrome. And then you can get better, and you might feel a lot better. But decades and decades, and you feel better for so long, like 20 years, and then suddenly you start to degenerate very quickly, and you get neurosyphilis. And you get cardiovascular things like aortic dissection, and it can go to the fetus. In fact, you can actually unknowingly transmit it to a fetus and get congenital syphilis, which is also very severe. I've seen someone with neurosyphilis. It causes like huge cognitive changes. It can cause coma. It's really severe. And this typically happens like 20 years later, like many decades later. So it's important to know about. The way that you would test for this is you would never culture it because that's never fast enough. Instead, you would do these specific tests. So these are called the non-treponemal tests, and these are the treponemal tests. So TPHA is a specific hemagglutinin that's only produced by treponema, whereas the others, like rapid plasma reagents, they don't specifically test for treponema, they just test for the antigen. Lastly, the way to treat syphilis is always going to be high-dose penicillin. It's another buzzword, high-dose penicillin, unless you're really severely allergic to penicillin, in which you'll have to figure out a way to... There's really no other drug that works as well. It's high-dose, yeah. So I didn't do anything about contraception, which actually is quite high yield. I thought maybe in your clin skills for lecture they would cover that. But other than that, I think I'm done. Do you have any questions? All good? Sweet.
Thank you.